Hello, everyone. Welcome to another, who knew I'd be doing this again, Saturday morning YouTube Live. I am so excited to have you here. We already have a good number of people here. And today, as our title indicates, we are talking about mental health documentation in the Trump era. So I do want to iterate that this is actually going to be a discussion on client care, on documentation, and it is happening because of a lot of uncertainty and confusion around documentation practices that has been in place, I would say, for, I don't know, indefinitely, forever, and has increased dramatically. So I have gotten so many more questions about sensitive topics, how to document things, considerations about how to share information, when to share information, etc. So we are talking about all of those things today. I'm very excited. And if you don't know who I am, hi, I'm Dr. Maelisa McCaffrey, founder of QA Prep, author of this awesome new book over here, Stress-Free Documentation for Mental Health Therapists. And all of that information is linked down below in the description, so you can check that out if you want to. You just have to click on the description to open it up and see all of the links that are there. All right, so let's go through how this is going to work today. And what we'll be talking about and our whole agenda, okay? So number one, yes, there are some controversial topics here. The focus I will have is on how do we document these controversial topics. It really should not matter what your political leaning is around, for example, abortion, around immigration, around transgender issues. If you are seeing someone who is presenting with those issues, how do you document that? And ideally, we would all have a very similar practice of doing that, regardless of our political views, right? So that will be the focus today. As these topics come up and as I bring these topics up, I do want to make sure that everyone here is respectful. There is a chat open. You can use the chat if you want. Today, I have a lot of questions that have already been submitted and that I have queued up in order and by topic so that we can stay on topic. So I will not be going through as many questions in the chat as I typically would on a YouTube Live, but you are welcome to post, if you are the question asker, additional information in the chat. You are welcome to share resources with one another in the chat or to comment on things or to ask follow-up questions. I'm not going to promise to get to all the follow-up questions, but you are welcome to put those in there. But I want you to remember that you are in a public space and to treat that chat as if you were in an actual physical room with other clinicians and as if you were talking either directly to me or directly to another clinician, and other clinicians are watching you do that. So whether you are watching the recording and this is about posting comments, or whether you are in the chat right now, remember that to respect. Be respectful or you will be removed, right? Your comment can be removed or you will be removed from the chat or from the live. So please be respectful, and you can be respectful and disagree. I welcome that. That is perfectly fine, but do so in a professional way. All right, so today we are going to talk about quite a few topics. And as I go through those, as I was looking through the questions ahead of time and looking at all of the different topics that were coming up, I came into some kind of general recommendations that speak to the overarching themes related to all the topics. So I'm going to open with that and talk about some general recommendations around sensitive topics. Then I will go through and answer all of the 21 questions that were submitted and group some of them together because there were a lot of commonalities there. So, but if you submitted one of those questions, it will be answered. So keep an eye out. I'm going to go through those in a specific order. So first, we're going to talk about generic sensitive information. So documentation questions related to sensitive info, but that aren't specific to any one topic area. Then we're going to talk about transgender and LGBTQIA plus clients and documentation there, mostly transgender clients. Then we're going to talk about pregnancy issues, pregnancy loss, pregnancy, fertility, all those things. Then we are going to go through some general documentation questions that I got. So I did receive some other basic questions like about treatment planning and updating treatment plans and things like that. But those will be near the end because the focus of today is on sensitive issues. So that way you have a game plan and where we will be going. I do also want to highlight that I have personally changed my mind about some of these recommendations that I'll be giving in some of these topics. So there are things that I used to recommend or used to, maybe my recommendations haven't changed so much, but my thought process around privacy and also around access to documentation has shifted a bit for certain topics. So what does that mean? Well, for example, 5 years ago, it wasn't illegal to get an abortion. So that's just a very real, again, regardless of what you can think about that issue, that is a fact. So now that is a very different type of thing to document. If you're documenting that someone is talking to you about considering something that is illegal, it makes sense that now the guidance and the considerations around documenting that issue are very different than they were 5 years ago. So just as an example, that is why some of the recommendations are kind of shifting a bit on my end. All right, so let's get into it. So I want to first address the fact that people are nervous, right? So people are nervous about documentation, about how information will be perceived, and about ultimately about the negative consequences or potential negative consequences for clients. So I encourage you to ask yourself anytime you're having any of these questions or anytime you are worried about what you're putting in a note, even if it's unrelated to these specific topics for today, look at why are you nervous? So really think about why is it that I am anxious about documenting this particular topic? What is it that I'm concerned about? What are the ramifications I'm concerned about? And if we start there, I'm going to give you two principles, two things to pay attention to first. And that way you have a framework regardless of whether or not I answer your specific question today. So number one, we're going to look at informed consent. And number two, we're going to look at making sure we do a reality check. Okay. So first off, informed consent. With all of these issues, and as I go through and answer specific questions today, you will hear me reference informed consent. What does that mean? Make your clients aware that you are documenting about them, right? Make your clients aware that they have progress notes. If you have clients who work with insurance, make sure they are aware that their notes could be read by that insurance company. This is not new, right? This is something that has always been important, has always been a key foundational aspect of all of our ethical principles and codes of conduct. And it's something that I personally think many therapists have avoided related to documentation because we often don't want our clients to see our documentation. And there's a lot of reasons for that. But in a nutshell, a lot of therapists just don't want to share their documentation with clients. This is a great time for transparency and documentation. So if you are concerned about what to write, how to write, and what might happen if you write it, that is something you should be talking with your clients about. How you have that discussion, how much detail you go into will vary on the situation, will vary on the client, etc. But talk with your clients about it. So ask them what you want them, what they want you to write. That is totally legitimate, especially if we're talking about things like gender identity and pronouns and things that are very personal and literally related to someone's identity. Ask the client what they would prefer. If you are worried about it, don't spend half an hour sitting there agonizing in front of a computer or in front of a piece of paper on what to write when you haven't even talked to your client about whether or not they're concerned about that issue, how concerned they are about it, and what their opinion on it is or preference for is. So that's my first recommendation, is really let clients know that you document, what you document, and how it might influence them. And then when in doubt, or when things are in question, or when it's not explicitly clear, ask them about their preferences. You can also go through documentation with them and say, this is what I've written so far. How do you feel about that? Would you like me to change the way in which I'm doing that? I will say that not all of these requests, for example, if you go through your paperwork with a client and ask them about if they have preferences and if they would like things changed, that doesn't necessarily mean you are going to do exactly what the client wants all the time. For example, if they say, well, yes, I want you to bill my insurance. Yes, I want, this type of thing documented, but I don't want a diagnosis. Well, that literally cannot happen. I cannot bill to insurance without a diagnosis. So that is where it's not a matter of trying to, do everything that your client wants. It's a matter of giving them the options, making sure they're informed of those options and what the potential results or consequences are of each one, and then empowering them to make that choice. So really always go back to informed consent. This is something I go back to all the time in so many areas of documentation. Someone's expecting me to answer a question about a progress note, and I'm actually talking about informed consent. So always go there first. And if you take anything away from today, I will go through very specific things and give examples and answer very specific questions. Anything from today, the most important thing I want you to take away is that this is a good time. This is the perfect time for transparency and documentation. So let your clients know what you're writing. Ask other clinicians what they are writing and how you can write, and make sure clients know what is happening. All right, so number 2, if you're feeling nervous, is a reality check. So let's do a reality check, because often, we all know this with anxiety, actually looking at the situation in reality can help us with solving the problem and looking at it more realistically, so that it feels more manageable and less mysterious, right? So here's the reality check. A lot of people are talking about being concerned about insurance, or, are my records going to be investigated by Doge, or, is Elon going to have access now that, his team accessed Medicare or Social Security records? How much information do they have? These are very real questions people are asking. And here's the reality. Regardless of who, I won't say regardless of who, I will say these particular entities, and especially insurance companies. Insurance companies have a lot of power, and I don't expect Doge to be going into private or commercial insurance companies and accessing those records anytime soon. Never say never. I'm not predicting anything, but I will say those entities also have a lot of power and influence and money. And whenever we look at insurance, and whenever I talk about medical necessity and documentation related to that, I always remind people, look at their motivation. Their motivation is money, okay? They are looking at the money, and that is their motivation. Is they're only looking at documentation most of the time for the purpose of, can we save money? Even when they are doing it under the guise of client care for managing, for example, high utilizing clients who have a lot of medical problems, clients who have also a lot of mental health problems and are frequently hospitalized, and they are genuinely reviewing care to make sure that the client is getting the best care. It is so that they can spend less money on that care in the long run, right? So looking at that can help us step back and see where we actually need to focus. So that's one thing. The next thing is to remember that risk scales. So if you are in solo practice, if you are a private practitioner, if you're a counselor with a private practice, you are viewed very differently than a mental health agency or a hospital or a very large group practice, even to Medicare and Medicaid, right? And again, Why is that? Why would we expect different things at scale? Why would a licensed clinician with the same license type in the same state have different standards based on the setting in which they're working? It is because, again, a lot of that is because of money. So it is far less fruitful for Medicare to come in and audit you if you are a private practitioner with 10 Medicare clients than for them to go in and audit an agency that has 1,000 Medicare clients, right? They are more likely to find something, they are more likely to find more, and they are more likely to get more money back, even if they found 10 problems in each of those scenarios. So risk scales. So at the private practice level, you do have less risk as far as audits, people wanting access to your information. That doesn't mean you have no risk, but it also means that if you had a review or an audit of some kind, your potential consequences are definitely less. So, for example, a lot of Medicare, Medicaid will commonly, if they do an audit of a private practitioner, an independent practice, they will create like a 6-month, what's the word I'm looking for? A plan. I can't think of the exact word right now off the top of my head, but they will create a plan for you and then come back and review that plan. So you'll kind of be on probation, like a probationary period. They are not doing that for a large agency because they go into that agency every single year and do audits and give them feedback. And because that agency is supposed to have a whole training program in place and had to do a lot of things to be licensed and to get access to that, they often have supervisors and directors. So they're not giving them that probationary period. They're saying, you should have known this, so here you go. So remember that risk scales. That does help when we look at a lot of these things and get caught up in these fear tactics, because many of you who are in private practice started out in that agency setting where the risk was there in that way. And so you assume then that you have that same level of risk in private practice. And that is typically not the case. Lastly, I will also say, as far as this reality check point, have you opted out of Medicare? So if you are in the U.S. and if you are in the U.S., if you are a licensed therapist, okay, once you are licensed, if you're a licensed therapist in the United States, you need to choose if you want to opt in or opt out to Medicare. If you don't opt out, it is assumed that you are opting in, meaning it is assumed that you want to see Medicare clients and that you will accept Medicare. However, the reason you have to opt in is that although it is assumed, if you haven't opted in, you can't actually bill Medicare and get paid for seeing those people. So this is your reminder. If you have not opted in or out of Medicare, and if you haven't updated that, because you do have to update it, this is your time to do that. Put that on your calendar right now. You can go ahead and find wherever that is and make sure you schedule that. It doesn't take that long. I do have a link to a resource from Barbara Griswold that walks you through how to do that. I will add that to the notes for this video. If you want to look that up right now, you can just Google that, Barbara Griswold, opting out of Medicare. You will probably come across the exact same resource, okay? So do remember that, because the thing is with Medicare, Medicaid, that is state and federal insurance. It is different. And so if you are nervous about these things, I would encourage you to choose either way about that. And then related, if you are very concerned about insurance, you always have the option to end insurance contracts. You may not want to do that, and that is totally understandable. But if you're really concerned about it, that is an option you have. And you can always end insurance. You don't have to end all insurance, right? You could choose to not be paneled with certain insurance companies anymore. So those are things that you do have the power to control and that you can manage. All right. So remember those two things. Informed consent is always, always, always first, and reality check. Okay, what are the actual more realistic consequences of different things that I'm concerned about? All right, so now we are going to go into our whole summary of questions. So I think I mentioned I have 21 questions. We're going to start talking about sensitive information first, and then go into transgender issues, then go into pregnancy-related issues, and then other general documentation questions that I've received. Okay, so I did reword some of these. If you are here listening for your particular question, you should be able to very clearly find it. But I did not include any names, and I did simplify a few of them. I also will answer a few of them together because they were very similar. All right, so starting off with number one here. I'm nervous about assessments and biopsychosocials. How much detail can we leave off of these and still have insurance cover services? So again, I would look at why are you nervous about assessments and biopsychosocials, right? Assessments and biopsychosocials are not they are not meant to be for insurance. They are meant to be something we all do regardless, right? So we would be doing that regardless of whether or not we created a diagnosis and billed insurance. Everyone does varying levels of detail with assessments and biopsychosocials. It's not something you have to all do in the first session. You don't have to do it right away. I would encourage you, related to this topic, to check out a book by Dr. Daryl Chow called The First Kiss. I will link to that in the description later. It's a great book about the intake process and about rethinking the intake process and making it focused again on the connection with the client. I do think you can do that while still fulfilling insurance requirements. So if you do work with insurance, yes, you need to include enough information to justify a diagnosis. That is the foundational piece of all insurance billing, and you must do that. I would also argue that if you have a client that meets criteria for a diagnosis, that is also good clinical care to do that. And here again is where we go back to informed consent. If you're concerned about that, that is not your decision to make. That is your client's decision to make. So ask your client, tell your client, I want to make sure you know, if you bill to insurance, I will have to give you a mental health diagnosis, and that will be in your record, and your insurance company can access those records at any point if they are paying for this service. That's if you do a super bill or not, right? And so let the client know. And if the client says, sure, that's fine, I don't mind, I would like to know, let the client know what their diagnosis is. Talk with them about it if they have questions. These are all very relevant clinical issues. But I see no reason for avoiding mental health diagnoses or, trying to fib or work around that. Include the information that is necessary for that diagnosis. And yes, sometimes that information relates to trauma if the diagnosis is PTSD. It does not mean you have to include all of the nitty-gritty details of someone's sexual trauma that they experienced as a child, but you do need to include that piece of information. For example, that they were sexually abused as a child. That might be very, very relevant to the diagnosis. So always remember that there are other people and other reasons for documentation, and that kind of goes into our next question. So I will go there. What are your recommendations for making documentation meaningful? Meaning that I can remember it and build off of the information while also protecting clients. This person uses therapy notes, and they're wondering if having a vague note in the progress notes and creating a second psychotherapy note would be helpful. I don't really want to get into having two sets of notes, but I want to protect the client. My notes are way too long and detailed, and it takes me forever. It's hard to write for the client's record, for future providers, for insurance, for me, and for the government, all in the same note, and spend way too much time. So I'm sure many of you are familiar with this, managing all the things and all the people. Okay, so number one, let's talk about, remember that your documentation is not meant necessarily to protect clients. Your documentation is meant to document what happened. And when we get into picking and choosing a lot around that, then we can get ourselves in trouble. And so we do not want to focus solely on picking and choosing from every session what may or may not help our clients. Because here's the deal. regardless of what you believe and what might be happening in the moment, it is nearly impossible for you to predict what might help or harm them when you start getting into that nuance of adjusting factual information. So really you want to stick with what happened, this presented, and think about what literally can you see, feel, hear. Those are the types of information that you want to stick with. And then when it comes to client process, expression, you can go into a little bit more detail there. You do not have to go into detail about trauma narratives, I think is one of the things that most people are concerned about. We will talk about transgender as a whole other issue after this. So I think that's one where people can get into a little more nuance. So the issue of having a second set of psychotherapy notes, I really wanted to address this. Thank you for asking this question. That does not protect your client or you. So HIPAA gives special protections to psychotherapy notes, which we often call process notes. HIPAA does that as a federal law. I would say trends that we are seeing are towards deregulation, not more regulation, right? So from a federal perspective. So let's not focus on that and instead focus on what is your state law, because your state law usually is going to override HIPAA. HIPAA is the bare minimum for privacy and protection. Your state law almost always goes above and beyond. And not also privacy and protection. There is access. Access is half of HIPAA. It is a key part of HIPAA. And we often focus more on the privacy and protection part of it. That is important. But client access, meaning I get to access my own records, is half of HIPAA. It is half of the purpose of HIPAA. So when we look at it from that perspective, a lot of states say that, yes, you can have these separate psychotherapy notes. HIPAA has this whole definition of what you need to do for them to be categorized as such. And we still say that is related to that person's care, and that person has access to any documentation related to their own care. So do not use psychotherapy notes as a way to protect information. That is a really common way that a lot of therapists become very surprised in a negative way. So also, psychotherapy notes might be protected under HIPAA. That does not mean they are protected against subpoena, right? Nothing is protected against subpoena. We can subpoena whatever. A judge could always override that in a court case. And so you could do the whole, I'm asserting my privilege and I don't think these psychotherapy notes should be released. And a judge might agree with that. But your psychotherapy notes can absolutely be subpoenaed. So it does not protect them from that. And many state laws would actually just override that altogether and say, absolutely, clients have a right to those notes because it is about their care, their health care. So do not write two sets of progress notes with the intention of hiding information. Really, and even if you do find psychotherapy notes to be helpful or process notes to be helpful, you should consider what you're putting in those notes and who might access them and the fact that they are not protected from subpoena. So do remember that when you're writing those notes. Okay, then as far as thinking about all of the different people, right? This person mentioned future providers, insurance, me, the government, all in the same note. This is where I would say, yes, all of those parties potentially could access client information, potentially could read a progress note. How likely is that? When we look at what is likely, what is worth these large entities' money to seek access to your client's information, often it is not, right? Or for insurance, it's going to be related to medical necessity. They really don't care about the personal story of the client. That's just the reality. They are interested in, is this person getting better? Do we need to keep paying for this service? That's what they're looking at. And so from that perspective, they do want people to get better. They do want people to improve and have fewer stressors, et cetera. But it needs to be related to that diagnosis. So for insurance, that's fairly simple. There are lots of resources I have on that. I would focus more on you, what is helpful for you, because that's something only you can answer. There might be some odd thing that you like to say. People tell me, oh, I have this way of phrasing things with clients at the beginning of session, at the end of session. We always start off sessions this way and end sessions this way. And that's really awesome. And if you find that helpful to track that information, put that in your note. Anything that you find helpful to track, put it in your note. And then the key there is always default to letting your clients know that. Make sure your clients are aware of what goes in their progress notes, what goes in their assessments, what goes in their treatment plans, and if they have concerns, that they can talk to you about it. That's really the most important thing. All right, then someone said, should we avoid documenting if a client is experiencing stress, trauma, etc., due to socio-political climate or government policies? And this is, I should have included this in the information at the beginning. All of my answers are always, it depends. So this will depend. And always default to your own clinical judgment, your own professional judgment. That is really key. So you're watching something like this because you want to get information from, someone who is an expert in a topic area. I'm giving you that information, and you know your clients best and you know that particular situation. And so incorporate my advice and opinions as a piece of information and guidance, and then do what is best for you and your clients. Okay. But more specifically, to answer this question, I think it's okay to include that someone is experiencing stress or trauma around, I probably wouldn't use the phrase political climate. I might use the phrase government policies if it relates to them specifically, right? There's being concerned about what's going on in the world, and there's being concerned about what is changing policy-wise. And then there is this policy changed and now I'm fired, right? That's a very different result. But I would say, talk about someone's stress or trauma or distress, related to changing policies, related to confusion about policies, related to whatever that might be. I think it's perfectly acceptable to say that. And we have to remind ourselves that that is something that people experience every election period. Do I personally feel this is a little different than usual? Yes, I do. And I also acknowledge that every single time there's an election, people are distressed, people are concerned. Every time a law changes, one way or the other, there are people who will be impacted. There are people who will be distressed. And it's okay to include that information in your progress notes. And the way that you worded it actually is very vague. You don't have to go beyond that. You could just say that the client brought up, stress around how government policies have impacted their work or something like that, or how they are concerned about how they might impact a certain aspect of their life. That's very real and makes sense to include, I think, if it's something that is distressing to the point that someone is talking to you about it. And you can always go back to, if you're working with insurance, does this relate to the treatment goals and the diagnosis? If it has absolutely nothing to do with either of those, and you talked about other things, then you could leave this information out, because it might be relevant if it keeps coming up in the long term. But if it's a one-off thing, and you also talked about, for example, their anxiety and how it showed up in a social setting, then I would focus on that, because that is likely more related to the treatment goals and the diagnosis you have. So always, use that lens first, rather than we can get very, it's very easy, as we ourselves are stressed about things, to then focus in on one particular aspect of a therapy session, rather than taking a step back and looking at it again in the context of, how would I always recommend you write a progress note? Always look at the diagnosis and symptoms and look at the treatment goals. And what did you do today in that session to address those things? And if you didn't do anything to address those things, that's okay. You just don't want to do that 10 weeks in a row while you're billing insurance, okay? All right, so next question. I work with an agency that has an EHR system that allows non-clinical staff, so people like an intake coordinator, outreach specialist, data person, case manager, etc., access to clients' assessments, treatment plans, and progress notes. Is this breaking HIPAA? So I added this question in the sensitive information section because this is a process that has been going on in forever, like ever since agencies have existed. So as far as I'm aware, this is not a new concern. And it's not actually related to HIPAA, but I can see how people might be more concerned about who is accessing information now, if you are in general concerned about that. So is this breaking HIPAA? Absolutely not. HIPAA has to do with healthcare information and anyone who is involved in that person's healthcare. HIPAA gives, again, that special protection to psychotherapy notes, which are process notes, which should have nothing to do with anything that relates to being necessary for treatment. So it's supposed to be the therapist's just random personal musings, essentially, or ideas. And so it is absolutely not breaking HIPAA for people involved in that client's care, which sometimes is going to be an outreach specialist, which sometimes will be a data person who's looking at billing, which sometimes will be a receptionist who is helping with scheduling and needs to answer people's questions or update forms and things like that. This is a very common practice. And within HIPAA, HIPAA gives very general frameworks that are scalable, as we talked about earlier, for individuals as well as large entities to follow for privacy practices. And one of those things is if you are a larger entity that is going to have all of these different types of people accessing records, then they are also supposed to scale that access to the records. So for example, someone who's an administrator, someone who's a clinical director might have access to all the clients, whereas a case manager should only have access to their clients. A therapist should only have access to their clients, right? Likewise, multiple people might need to access all clients, like someone who is an intake coordinator or someone who's a data person, but they don't need to access every aspect of the client's record usually. And so that's why these, when you work at agencies or hospitals or bigger settings, they often have very robust and sometimes complicated electronic health records because it is offering these different levels of access to information. So it should be set up that, typically a data person, there are often multiple roles, potential roles within an electronic health record. And so a data person might have access to all the clients, but a very small portion of client data, whereas a therapist might have access to pretty much the whole record, but only of a small number of clients, right? So that is totally within HIPAA and okay. And if it's something you're concerned about, especially if it's something that that you notice is being abused or misused in any way, then talk with leadership at that agency about that and ask them their recommendations. All right. Transgender issues. So let's get into this one. So first question is it necessary or reasonable to remove identifying things related to being transgender or undocumented clients? Should we avoid using pronouns? What about using gender dysphoria as a diagnosis? And related, there was another question that said, regarding adult clients, can you offer guidance about how to best go about documenting gender dysphoria, when or if to include the diagnosis and documenting symptoms to support it in client charts in the current political climate? So, okay. I think this is coming up a lot for therapists who have been seeing clients who are transgender and been treating them specifically for gender dysphoria and now are concerned about it. And so now it's like, it would be easier if a client was just coming in today and you could have policies and structures around that today. But what do I do about 2 years of notes for somebody that has all of this stuff in it that now feels a little concerning. So as far as pronouns, as far as documenting whether or not someone is transgender, my personal recommendation would be to default to what the client's preference is and to ask them. So to ask them literally, do you want me to include information about you being transgender? Do you want me to include which pronoun would you like me to include in my progress notes? And is that different from how you want me to talk to you in person? Right? Those are questions I would specifically ask clients. Especially, I would say this is a group where when we talk about other sensitive information, certain clients aren't as concerned as we are. Some clients might be, but a lot of times many clients aren't. I would say this is a group where this is likely top of mind for this population because they are really involved in the healthcare system already, and it is directly related to that issue. And so I think for transgender clients, I would recommend bringing this up, even if they haven't brought it up, and talking with them very openly about it, giving them access to their records or reviewing records with them to talk with them about it, because that will be both empowering for them and help, again, clear some of that mysterious aspect of the documentation. And I think will help the two of you determine what is the best course of action. The answer here might be different based on different clients and based on different settings. For example, it might be different if you are working with insurance and the type of insurance you're working with, or where this person works, than if this is somebody who is less concerned about how this might impact their job and they're paying privately, right? So ask your clients about it, and that is what I would default to. As far as using gender dysphoria as a diagnosis, this is where I would love to say if that is appropriate, then use that diagnosis. Here will be my caveat. It is fraud. It is technically insurance fraud to not give someone an accurate diagnosis. And this especially insurance fraud, to purposely choose to give a different diagnosis than would make sense and then aligns with, and that is different from the symptoms presented. And you might have a justifiable reason to do so. That is up to you. And again, I am kind of informed consent-wise giving you the information and the options for you to make that choice yourself. I would encourage you not to make that choice alone. And if you are worried about it, to talk with that particular client and ask them again. For different clients, there may be different ramifications here. So asking them about it. Personally, I probably wouldn't document that conversation. I might document a conversation about doing a records review with the client. I don't think I would document much more than that. And that's a very legitimate thing to do. You could talk about you reviewed progress and did a records review. That's a very clinical task that any insurance company should be happy to see. So you can absolutely include that as your documentation, because this might be a whole session, right, where you talk about this and review different things and go through different scenarios with that person. So that's what I would recommend. I wouldn't say never use it, and I wouldn't say always use it. I would also make sure that you do have other diagnoses that might make sense. So if depression or anxiety or a trauma-related diagnosis also makes sense for this person, also include that because often they do, and that might help with a lot of the concerns that you have. So absolutely include other diagnoses as applicable and make sure that you have treatment goals related to those, so that everything is justified for continuing to see this person based on those symptoms and those needs. All right. The next person said, if you're supporting trans clients with gender-affirming care letters, what do you document? Do you save the letter you wrote in the file? Again, normally I would say yes, that you would, if you wrote a letter that is very specifically related to the treatment you're providing someone, I would say yes, include the letter. And here is where I could say, okay, keep the letter separate. But just like we talked about with HIPAA and with psychotherapy notes, if you keep the letter, then it is still part of that person's medical record, and people could access it 100%. That would be a legitimate thing to assume. And I would assume that if you keep any such letters, that they are discoverable, right? That they could be accessed, requested, subpoenaed, etc. So do assume that. And then again, I would ask the client, do you have this letter? Do you have a copy of it? Make sure you do, if that's appropriate. Would you like me to keep that in your file? And if not, then you can simply say that you wrote a letter, that you wrote a case summary letter, or that you wrote a letter updating diagnosis and treatment goals, like a treatment summary letter. And so I think you could legitimately use that in your documentation instead of saying that you wrote a gender affirming care letter. And again, I mean, that's something that is going to be requested by the client and need an authorization anyways. So ideally you're having that conversation. But I would add to the conversation, not just about, do you want a letter? Who do I send this to? I would also add, do you want this in your file? Would you like me to keep a copy of this in your file, or would you like me to destroy? And those are the options. Would you like me to keep a copy of this in your file, or would you like me to destroy the letter after? Because if you cannot keep it in some separate place and expect that it is protected. So I would consider those two extremes, that it's either in the file or it's destroyed. Okay. Next question. So this is a little bit more specific, but I think also very helpful for everybody to hear. I'm a community provider that's independent, but for the VA. Among my clients are transgender veterans who have been receiving services through the VA. I'm required to provide medical documentation. They have been sent to me with a diagnosis of gender dysphoria. Of course, I always add on anxiety or adjustment disorder diagnosis. 2 of my clients have been denied continuation of therapy with me and there's no reason given. Moving forward, should I ever include a gender dysphoria diagnosis on any documentation? If I'm already working with these clients, should I omit that diagnosis in future documentation, even though it's the reason they were referred to me? So in this particular example, I don't think there's much benefit in not including it because, as you said, they're coming to you with that diagnosis. They will be receiving services through the VA. It's already documented through the VA. You can't get much more public than that. So it's already there. And if it's in their file in the VA, it's likely not going anywhere. So I don't think that your removal of the information is going to serve any purpose unless you genuinely disagree and you would not include that diagnosis because you do not feel they meet criteria for that. That's a different story. So whatever way that you are working with them, I would, though, as I said earlier, focus on what are the other diagnoses that might be relevant and make sure that you have treatment goals specific to those diagnoses and that you are addressing those treatment goals in therapy as well. And I would just, I'm not saying this about this particular person, but because I do hear this frequently, I want to remind you all that, just adding random anxiety or adjustment disorder often is not good enough. Really do a thorough assessment and make sure that whatever the symptoms that are presented match the diagnosis that's given. And remember that adjustment disorder can only last for 6 months in the eyes of almost all insurance companies. So don't rely on that one all the time. All right. Another question I got that I wanted to address was very generic, and it said, how do we protect the LGBTQIA+ community? This is where I wanted to bring this up because, number one, I wanted to address all of the questions that I got. But number two, I think we really have to focus on individual clients. So as far as documentation goes, focus on your individual clients and all the principles we've kind of talked about already with informed consent and with talking with people and making sure they have access, transparency, and are empowered to make some choices. And then as far as protecting the larger community, that is really where I think then you go into the messaging you have on your marketing materials, your website, the way in which you present your intake paperwork, making sure that that is affirming or that that is very open, and any other advocacy efforts that you want to do. But with documentation, keep it focused on that individual client, because it can be very easy to start grouping people, and still within that community, they may have different preferences, right? Each person might have a different preference for how they want you to document different things. So I would actually encourage you to keep it focused on the individual. All right, for pregnancy. So we're going to move on to pregnancy related topics. And I'm going to keep going. I know there is lots of good stuff in the chat, and I appreciate this. I thank you all. And it looks like everyone is being respectful, which is awesome. So thank you all. Continue with that. But we have enough questions here that I want to make sure we get to all these. All right, so now we're going to talk about pregnancy-related issues. So the first question is, I'm trying to figure out how to document pregnancy loss and how to document the impact of it while maintaining as much privacy for my clients. And it's very similar to the next question that I want to get into as well. I work in maternal mental health, and I'm really struggling with how much, if any, information I include around pregnancy, loss, live birth, etc. If you could speak to how much or how little information to include, that would be helpful. Most clients are identifying birth trauma, loss, anxiety after pregnancy, etc. in their intake forms. Should I tell them to be more general and focus on symptoms? I find it helpful to have that information, but have growing concern that it's in their documentation. Okay, so this is a really great example of how we can adapt some things. So one thing you might, here's where you do have to test, and there's no wrong answer, okay? There is no wrong answer as far as having it continue to be an open-ended intake process and using the client's words. I find that extremely helpful to have a generic question, and it sounds like you have, where they are identifying specific things and giving you information about why they want to see you, what they are struggling with, what they want help with. Having it in their words is very valuable. If it feels like that is okay in your state, this is where it might be state dependent. So if your state doesn't have specific laws around pregnancy related issues, around fertility, meaning that clients could not be criminalized for certain actions, then you might want to just keep that generic list because you're finding it helpful. And I agree, it's really helpful to connect with clients more quickly. However, if you work in a state where clients could be criminalized for certain things, then it would make sense that you might be a little bit more wary about having things documented, right? And so in that case, what you might want to do is have a checkbox or a checklist instead. So, for example, like in my intake paperwork, it's available in my book here, I have a symptoms checklist. And so that is something for clients to fill out that's very quick and easy. And that way you are, instead of asking them to put it in their words, you are instead giving them a pre-created list of options of many things that potentially could come up. And if you work in maternal mental health, you could make those much more specific than I have in my checklist in the book, for example, because that covers generic mental health issues. And so you could have a symptoms checklist, have them check off what is what is concerning to them. And I like a generic checklist because oftentimes people will check off things that they wouldn't think of to write on their own, just because they see it and they're like, oh yeah, I have been struggling with sleep, but they weren't thinking of that in the moment, for example. So you could have that, and then you can have a question after that that says, what are the top two, or top 1 to 3 most concerning things or most stressful things out of that list. And then most people when prompted with a question like that, will just write down what you have already given them, right? They're not going to make up a new word. And that is potentially an option, but most people just write down exactly what you ask them. And so then you can use your intake session to dig into that topic more. So that is an option to still get really good data and integrate it in the intake process, but to avoid potentially people including information that could be harmful or that could be used against them in some way. And then let's see, as far as writing it in notes and things like that, how do you document pregnancy loss, live birth, birth trauma, anxiety after pregnancy, all the things that someone might be talking to you about? And I would say the way that that everyone here has worded these things are perfectly fine. Pregnancy loss, pregnancy, anxiety around pregnancy. That is very normal, whether you are excited about the pregnancy or not, right? To be anxious about it or to have other feelings about it, to be stressed about the circumstances around the pregnancy, to have trauma around your birth, to have trauma around hospital visits or being pregnant or medical providers. That is not new information, and that is not specific. Really, the concern here with pregnancy most of the time is around abortion. And all of those things are true regardless of whether or not abortion is legal in your state. So those are all, I think, great phrases to have on hand. And that's what I encourage people to do, especially if you do work with a lot of new moms, maternal mental health issues, perinatal issues, then have some of these phrases pre-written out for yourself and have a little cheat sheet for yourself so that you're not wondering how to document things. And even write out full sentences or bullet point phrases for yourself so that you can just copy paste a lot of phrases and terminology and not have to think about it in the moment. Okay, so then somebody asked, what is necessary to document regarding a perinatal or pregnant client? And so that is another it depends question, right? I would say the fact that someone is pregnant is likely important to document, and likely if they brought it up to you, it is a topic that is likely to come up, right? It's likely to impact treatment. If someone is on medication and they become pregnant, they have to talk to their doctor about it. That might impact their mental health. That might be something you're talking to them about, right? The stress around if they choose to stay on that medication and their concerns about it. I mean, these are all things that are likely to come up and that come up in therapy all the time. And so I think that can be an important thing to document. Again, typically most people's concern nowadays is what if that pregnancy ends? What if it's lost? And do I need to document the circumstances around it? And I would say no, that you can just document that there was pregnancy loss and then focus on the emotions around that, the process around it, the stressors around that, because there are going to be stressors around that regardless of the situation. So focus on those things. And again, on the mental health symptoms, the diagnosis, the treatment plan goals that you have for that particular person. And also, if you have a client who becomes pregnant, evaluate if those things need to shift. The diagnosis might stay the same, but you might need to adjust some treatment goals, or you might need to add one in, and that might make sense. Or if you see a client who's pregnant and then is not pregnant, same thing. You might need to shift some treatment goals and adjust things. And totally okay to talk about grief, or other feelings related to pregnancy. I would mention all of those. Let's see. All right. And then someone asked, please address how to document concerns related to reproductive rights or reproductive health care. And so I would say that is just aligned with the other, my other recommendations, with have some pre-written phrases, statements that you can use and ways in which you plan to document that, and make it in relation to the type of people you see, right? So if you work with couples, this might be an issue that comes up. If you work with maternal health care, obviously this will be an issue that will come up. So have some of those things written out. If you work with kids, it might be less of an issue, right? So it's going to depend on your particular clientele, how prepared you might want to be for that topic. Okay, we are now going to get into very generic random documentation questions. So these are questions that do not specifically relate to these sensitive topics or all the things. And many of these questions I have answered in other videos. And so I have already linked in the description a few videos that you can watch that have to do with what goes in a progress note, what goes in a treatment plan, and then one about insurance documentation, and I forget what the other one is, but click on the description. You can watch, you can, either save those for later or watch those now or watch those next, right? So I will reference those as I go through these questions. All right, so number one, what must be in your notes as a standard for all notes? And for risk, what should it say specifically regarding interventions, symptoms, etc.? What needs to be in a progress note for it to be complete to pass any AI audit? So for this one, I'm not sure what you mean by an AI audit. If you are talking about potentially insurance companies using AI for audits, they are not doing that for looking at progress notes at this point. Remember that insurance companies, any information that they are using to determine who needs to be audited, what records to audit, is based on billing information, because they don't have access to your notes. They don't know what your notes say. All they know is the information that would be on a super bill or on a claim. And so that's going to be the diagnosis, the CPT code, so the billing code, which is what service you provided, and how much that cost in a nutshell. So all of their red flag systems and, systems for identifying who to audit are based on that information. And so that is something that's important to remember. Then if you're looking at an actual audit, that is typically going to be a clinician who would be reading your notes. So if you have an audit to that point, because again, a lot of times you might have a treatment review and it's not even an audit of your actual notes. An audit is literally, let me see this whole file, or let me see this file's notes from, October 1st to January 1st of whatever years, and then evaluating every individual note and document in that file related to that time period. And so if that is happening, that's going to be another mental health clinician doing that. And they will be looking for medical necessity. They will be looking for client progress and client need. And there is a YouTube video for that too. So I will guide you there. But for risk, what do you need to have in your notes? So as far as what needs to be in your notes in general, I will guide you to that. What goes in a counseling progress note video that's already linked below. For risk specifically, it's not necessarily about your intervention, symptoms, etc. What's really key to include is very fact-based information about why you have a concern, or what the risk is. So for example, this is where client quotes are awesome, because a client quote about, I've never felt this way before, I'm worried about what I might do, or on the flip side, yes, I think about killing myself, but I could never do that to my kids, right? Like those statements are based on, or those statements provide the foundation for your clinical rationale, because those statements give us very clear information about where someone is in relation to their risk and protective factors. So that is what you're really focused on when it comes to risk. So you want to evaluate what was the factual information that initiated this being, in the risk category, and then what are your risk factors for the client and what are your protective factors for your client? Because you could have someone give you the same initial statement, for example, about literally wanting to kill themselves, but end up with two very different situations after you do an evaluation or talk to them more based on those risk and protective factors, right? So that's really what you want to document: the risk factors, the protective factors, because you can never actually predict what someone will do, right? We can have a very good guess about someone's risk level based on that information, but we can never predict 100%. And so the key there is identifying your clinical rationale for the choices that you made in that situation. And when you give that clinical rationale, it's less about whether or not you did the right or the wrong thing, because oftentimes there isn't one specific right or wrong thing to do. It's more about, if someone is, typically in this situation, it would be a licensing board, right, that would be evaluating your notes. And what they're going to be looking at is, what was your thought process? And were you doing what would be clinically reasonable? Were you actually looking at risk and protective factors, for example? And did you act in a way that made sense based on your ethics and laws, and that you were working to clearly protect the client? And so there are circumstances there with risk where there could have been a very negative outcome, but if you did your due diligence, that is what your documentation is there to support. So focus on risk and protective factors. And then I will also say, the other big thing with risk I found from doing audits on many client files is the follow-up is frequently forgotten. So if you do have a risk issue that pops up, make sure that you're documenting that over the next few weeks as well. That you're documenting checking in about things or following up on what happened. But that is what I often find was missed, is the follow-up aspect. All right, so the next question: for insurance, are just checkboxes with medical necessity still sufficient, as you taught me? So I have a specific video on checkboxes. Are checkboxes bad for insurance? Here's the deal. I use checkboxes to actually just be bullet points. So I create them to be actual phrases, statements, not one-word things. When we're talking about, for example, things like interventions, even things like a progress statement, so a statement about ongoing symptoms or ongoing need, a statement about which area of life the client continues to be impaired in. All of those things are things that you can pre-create based on your specific clientele. And yes, if they relate to that client and that client's symptoms and diagnosis, that should be sufficient. But just using very generic checkboxes is not. So the key there is thinking of checkboxes, at least as how I teach them, as more of bullet points rather than checkboxes. They are bullet point phrases that you are pre-creating for yourself to save yourself time and effort. Let's see, what about private practice? I know we don't have to use medical necessity. What about the other parts of documentation like assessment, the closing summary, etc.? So, and I should clarify here. So for private practice, meaning if you're in private practice and not contracted with insurance, then no, you don't have to worry about medical necessity. And that is a very nice thing. And I think that you can still include most of the information that I recommend for progress notes. It doesn't really shift that much based on insurance status, because you're still looking at, how is this client doing? How are they presenting to me? What did I do to help them out? How do they feel about how therapy is going, right? Those are all things you're evaluating every single session, no matter what. And that should all be included in the progress note. Now, for specific things like assessments, closing summary, I talked about this at the very beginning, you're still doing an assessment if you are seeing someone, no matter what, right? Because you should be assessing if you are the correct person to help them out with the issue they are coming in for help with. And that is really the focus of your assessment. But you don't have to give a diagnosis, which is nice if you're not working with insurance. A closing summary, I don't think you need to do a closing summary. I think that your final progress note can be your closing summary. And I encourage people not to do a closing summary unless you have a contract that specifically states you need to do that. Otherwise, you are just writing the same thing twice. You're giving a little summary of all the stuff that's already in all your progress notes. And so just use your final progress note to close out the case, meaning to say, what happened? Was the ending planned or not? Is this the final session? What referrals are you giving? Include all of that information in your final progress note. Next question is a real big one. What should documentation look like for a couples session? So that is a whole training in itself. But in a nutshell, the key difference between an individual progress note and a couple's progress note is going to be the interaction. So you're still looking at how each person presented. You're still looking at what are interventions you provided. How do people respond to the interventions? What's your plan moving forward? Was there any homework that you gave? Were there any risk things? These are all things we're doing in any progress note for anyone. In a couple session, what's different is that you're typically guiding two people to interact with one another and tracking those interactions. And tracking the progress in therapy is typically about tracking the progress of them interacting rather than of one particular person. So that's what you want to add to your couples therapy notes is the interaction. So you're obviously going to have two client presentations because each person is an individual and will present differently, but then you're also going to make notes on how they interacted with one another. And that will be very influenced by the type of couples therapy you do. So are there specific phrases that you use based on, if you're an EFT therapist or a Gottman therapist, and are there different things that you're discussing, that you're teaching them? For example, like if you're a sex therapist versus a couples therapist who focuses on affairs, you might be, going through very different psychoeducational things. There's a lot of psychoeducation in couples therapy. So having those things pre-written out and included in your progress note is going to be the key. I'm wondering if I should touch on the fact that for couples therapy, if you are billing insurance, do remember that insurance only sees one client. And so your couples therapy is very different, documentation-wise, informed consent-wise, most importantly, if you are billing insurance for couples therapy. Because to an insurance company, that is one client. And the couples therapy is to help that one client. And so you may not need to use all of those aspects in your progress note because the couples therapy, the point of it is to address that individual's treatment goals and symptoms. So do remember that for couples therapy and insurance billing. And make sure that your clients are aware of that and that you have considered who accesses that record. That's really, really key to make sure that everyone is on the same page. You and both people in the couple are on the same page about who is the client and therefore who is not the client and who does not get to access records and who needs to consent to those being released. So those are really key things. That's a whole other thing. All right. Next question is, what needs to be specifically in a treatment plan and how often does it need to be recreated? So how often it needs to be recreated really depends on the need. So it needs to be recreated as often as it does. Meaning if you have a client who comes in for one issue and that issue drastically changes throughout the course of treatment, then yes, you need to change at least the treatment goals and maybe the whole treatment plan. I don't know. If you work with an insurance company, then you might need to, then I would recommend recreating the treatment plan at least once a year and checking in on treatment goals quarterly. So every 30 days, check in on the goals, identify whether or not you're continuing with those goals, changing them, getting rid of them, adding new ones, etc. And then you have a whole new treatment plan every year. As far as what specifically goes in the treatment plan, there is already a video for that. So I linked that in the description already. So you can check that video out. Next question. My understanding is that the full list of your client's symptoms go in the diagnostic summary and treatment plan. If the session notes do all, in the session notes, do all the symptoms that meet the diagnostic criteria have to all be repeated for every session or just the ones we address that day? Say they have full criteria for major depressive disorder, all the symptoms. Would I list just 2 symptoms in the note that I'm addressing that day or the full criteria every single time? So to me, this speaks to one of my 2 rules for documentation. And that rule is never write anything twice. So if you have already created the diagnosis and you already have that whole symptom list, which would have been whenever you assign that diagnosis, you would have identified all those symptoms together. I do not think you need to have all of those symptoms listed in every single note in copy-paste fashion, because what is the point, right? It is much more impactful, meaningful, interesting, useful to have just what you focused on that day. So I would recommend just including the symptoms that you addressed that day. And for those who do have questions about sensitive topics, certain diagnoses, you could adjust that, right? And just list all the same ones every time, or list just symptoms of the diagnosis that time. And that might work too. But as far as, what's most useful, I think, and what makes sense is just focus on what you did that day. We have 3 more questions here. So the next one is there a specific way to legally document that your services are for coaching rather than therapy? Additionally, how do you effectively communicate this distinction to clients? So I would legally document it. And I mean, is there a specific way to legally document it? It would be to close out the therapy case, like the therapy file. That should be a mental health clinical therapy file. And then you would open up a new file. To me, that would be the cleanest way to literally transition someone from one type of service to another. And knowing that as therapists, when we do coaching, that is very important to distinguish those two. I'm not saying that you have to do that. I don't know if that's the legal process, but I would recommend doing that because there is so much crossover and confusion with that particular topic. How do you effectively communicate this distinction to clients? That is going to be between you and the client and how you've been working together. So a lot of us do many coaching type things with people throughout therapy. And so why would you recommend to someone that they shift from therapy to coaching? And one way to think of it might be, okay, I think this person would be, that coaching would be more beneficial to them. Would coaching with someone else be more beneficial to them than continuing therapy with you? And so if the answer to that is yes, then there should be a very clear distinction about what that coaching, what the purpose of that coaching is versus the therapy you're doing with them is. If you can't make that distinction, I would argue that we are looking for other reasons to call it coaching when really we're doing the same thing we were doing with them before. So if you're struggling to make the distinction, think through it that way. Would coaching with someone else actually be the best fit for this person? Then you'll probably be able to identify why. So think about, what would I tell my client to look for in a coach? What would I recommend that they say they should be working on with their coach? Well, those are the ways that you can make that distinction to the client and also in your documentation. I will say, I'm not saying that this is what the question asker was saying, but many times therapists will transition a client to coaching simply because they have moved out of state and the therapist is no longer licensed in the state in which the client is living. That is very clearly not a reason to transition from therapy to coaching. Am I saying that it's not beneficial? Not really. I mean, I think it, for many clients, a lot of the times it would be more beneficial for them to continue with you, right? And to continue seeing you. But that is going to be on a client by client basis. And ethically, you want to be very clear on, if you do provide both coaching and therapy, what is the difference between those two? What does that relationship look like? And really, when we think about things ethically, it always goes back to, how does this help or benefit the client? And we have to take out our own benefit when we look at ethics situations like this. So it has nothing to do with what is going to benefit me, right? What is best for the client in this scenario? And really thinking through that and answering that question. All right, 2 questions left. The next one is, I use an AI scribe, Heidi Health, for documentation. And I should say it's Heidi, like the name, Health, Health, for documentation. It claims to be HIPAA compliant. Is it safe to use? Probably. So I have played around with Heidi Health, and I think it's actually a really great software. So it is an AI platform that I plan to review at some point and have a review on. It's probably going to be, of the next two, I think it'll be the second one that I do, because I do think it's very useful. It's very robust. And to me personally, it was the one where I logged in and it, for some reason, just felt like a clinician created it. And that's because a clinician did create it. It's one of the few AI platforms that a clinician started and not a tech person. And to me, that's very apparent. The way that you navigate the system and the way that it looks and how quick and easy it is to use. So I think it seems great. The key to determining if something is HIPAA compliant is whether or not they will offer you a BAA. If you don't have a BAA, you are not using it. You are not HIPAA compliant while using it. And that's one of the very few black and white rules I can give you. And so make sure that you have a BAA, or that they have, that they have initiated a BAA for you when you are using it. Let's see. And also, actually, this is related to the next question. We're going to talk about consent with AI. So last question here. I've been looking at AI for documentation, and I'm really excited about the difference it can make. I know I need to get client consent and use it for sessions, to use it for sessions. How do you recommend discussing it with them, with clients? And how is their consent documented? Is there a form, or do you mention it in the note for each session? I think similar to how we do for telehealth a lot of the time, right? Okay, so yes, do get client consent if you are using AI for any documentation. This includes if you are not using it in the way that, if you're using it after the fact. So if you're not recording sessions and giving AI access to the session data, you still want to get consent from clients and let them know, hey, after the fact, when I write my notes, in my record, I actually use an AI platform that is HIPAA secure to help me write out the note. So you can say it in plain language like that. That's totally fine. We don't have to overthink how we're saying it. Just clearly say it. If you can say it in one sentence, try to do that. Because here's what I find is that therapists often over-explain themselves. And especially when you're a little bit nervous about something. So if you're kind of wondering like, oh, I don't know how this person's going to feel about AI, and don't feel the need to explain yourself. Simply present the information. Let them know that you would like to use it for their progress notes to help with writing notes. Is that okay? That's it. And then ask if they have questions. Right. And if they have questions, you can dig into it. You could show it to them. Sure. Let me show you what it looks like and how it works. That, I think if I had any concerns about using AI, that would help tremendously. So offer that if someone is unsure and they don't know, if they're kind of like, oh, I don't know. Say, would you like to see what it looks like and how it creates a note for you? We can do that together, or I can show you what it has done in the past. Let them know. And then, is there a form for it? So most of these platforms actually do have a consent form. They know, like places like Heidi Health and Blueprint and Mentalic and Clinical Notes AI and Session 8, they all know that you're concerned about AI and that you're a little wary of it. And most of them, if not all of them, have a sample consent form you can download. Why not? I would actually... There's no rule around documenting consent for most of us clinicians at this point. I think that'll probably change in the future. But right now, I would say it falls under that category of new treatments or new modalities, where we do typically need to get consent from people and let them know we're using something or doing something that is new and untested and still changing. So most of our ethics codes do explicitly state we need to get separate consent from people if we are doing anything like that. I would say that AI falls under that category right now. So do get separate consent. Not all states require even, like a written signed consent form for even general therapy. So There's very little guidance about how that consent should be documented. If you can get a signed form, that's going to be your easiest, clearest, best bet, right? To make sure that you meet any criteria. But I can't tell you that there is actually a criteria right now. So if you just want to go with the most stringent thing and have a very easy, quick conversation with people and see if they have questions, then have them sign that form. Then you're most likely to be in the clear. And yeah, all right. And then let them know they can revoke that at any point too. So if at any time someone starts to feel uncomfortable about AI, they can always step back. That's the other thing, is that with AI, because it is in that new category, it's not the standard right now. If someone says no, you can't then say, oh, well, I can't see you. Or, oh, well, I'm not going to do notes for this person, right? So you still have to do your documentation, and you still would need to do it then without the AI platform. But my experience in talking with clinicians is that most people are okay with it. So it's highly likely that you can use it with most of your clients. All right, we are done with all the questions. So thank you all for being here, for asking questions, for being respectful and wonderful in the chat. And someone asked about the book on the shelf behind me. Yeah, that is totally new. I published that book. It released in October. So Stress-Free Documentation for Mental Health Therapists is very current. And it does address AI a little bit, but about as much as I could, anticipating that this will change very dramatically in 2 to 5 years. So, check that out. The link for Stress-Free Documentation is actually in the description for this video. So do check that out. If you are wanting more help with your documentation and kind of on all the things and wanting a framework as well as actual templates and cheat sheets, that would be my recommendation as your go-to, because you cannot beat that price for all that you will get for essentially a full paperwork packet, as well as guidance and training in how to use all those forms. All right, everybody, thank you for being here. If you are watching the recording, please go ahead and put in the comments your takeaway. And I would love to hear your takeaway if you are here live. You can also go ahead and put that in the comment. Thanks for being here. Thanks for submitting your questions. We will see you next week on another YouTube Live. Bye, everybody. Happy writing.